I want to get. I'm going to ask Tiziana. We are now have taken what we used to do first line, second line, give it all in first line. So what do we do when they progress? And I just want to quickly do this because I really want to get to oligo progression and ask Kristen to kind of walk us through, what patients are appropriately treated with SBRT or other techniques for oligo progression. So what's your go-to second line regimen?
So I think as a standard of care, the go-to second line is we're back to docetaxel. And I think the other option would be docetaxel plus ramucirumab. And I think, for a select population, ramucirumab can be a good option. I know the REVEL study was a positive study. We saw an overall survival benefit. I think a lot of us have concerns about toxicity, and is the added survival benefit worth some of the toxicity that we saw on the trial for patients that were trial eligible, and how does that translate to our patient population in real life? We saw at World Lung some studies regarding the use of doci plus ramucirumab, subset analysis of the REVEL study, looking at rates of neutropenia and showing that, yes, the rates of neutropenia were certainly higher when you add RAM to docetaxel, but the consequences of the neutropenia didn't seem to be different between the two arms. There are other toxicities too, though, that I think we still worry about. The additional thing that we saw at World Lung in 2018 was also looking at was there any additional benefit for adding ramucirumab for a subset of patients, and they identified in this subset analysis that for those patients who had rapidly progressive disease, some of the things that we're talking about, adding ramucirumab, adding ramucirumab to docetaxel seemed to be a better option for the rapidly progressive patients. Again, a subset analysis, but I thought it was interesting.
Yeah, so do people agree docetaxel with or without ramucirumab is kind of the de facto?
Well, assuming there's no trial, right? Because we all have so many different studies of post-IO.
We've exhausted the option of additional immunotherapy. I mean, as you say, we're adding vaccines, we're adding other agents, immunotherapy. We want to sort of eke out the time on immunotherapy as long as possible when it's no longer working.
And weekly docetaxel is much better tolerated.
Which gets to my point. And Kristen, I'm sure you see patients that your medical oncologist are trying to eke out that immunotherapy maintenance, right? or some maintenance, and they have one lung nodule that's growing, or they have one brain met, or they have one liver met.
Yeah, so SBRT is being used frequently now for patients that have oligoprogressive disease on immunotherapy. Interestingly, the phase 2 data that shows improved PFS with SBRT is in the de novo oligometastatic state. So patients that have typically between 3 to 5 sites of metastatic disease, low burden stage 4 disease. And that's really where the strongest data is for SBRT. And this is being evaluated in a larger phase 3 study, LU002, which I encourage you to put all your patients on this trial if they're eligible, and it's a really exciting question. Now, the oligoprogressive state is certainly something that we do in clinical practice a lot. Is there randomized data to support that approach? I would say right now, no, but it's something that is done in clinical practice quite often and does allow for patients to stay on their immunotherapy for longer and get more time before they go to potentially a less effective therapy.
Corey, your thoughts?
I agree. I think oligo disease is really 3 different groups. The oligo remnant metastasis, that was part of the Gomez trial, where we saw a striking PFS and OS benefit that, frankly, I don't think many of us truly anticipated. It caught me by surprise. And then the oligo progression, I would guess about a third of the patients we review at our tumor board are falling into that category. And until we really do not have prospective studies to help define the optimal approach.
Yes, and we do have some studies in the pipeline that are under development for the oligoprogressive patients. Also unanswered questions are what's the optimal SBRT dose, the optimal timing of when SBRT should be delivered for that patient population.
There's a third group, folks who've had definitive treatment for their either early stage or locally advanced therapy, and they recur, but in a limited number of locations, 1 to 3, 1 to 4. They have definitive ablation of the recurrence, so whether it's surgery or radiation or RFA, then what? there's no right answer. There's certainly no prospective studies, but in phase 2, we've looked at pembro in this setting and have seen median PFS now approaching 20 months and median survival that's not been reached. Now, could we do as well with other agents? It's unknown, but that's another group that I think we need a prospective randomized trial.